now have Professor Vinay Nangia. He's the head of the Suraj Eye Institute in Nagpur, one of the premier institutions in that area, and a prolific surgeon. So he'll be talking about how exactly to do the lens extraction in angle closure glaucoma.
Bas, thank you very much. That's very helpful. Thank you. Thank you very much to everyone who organized this conference in Calcutta and the AIOS. So I'm going to take you through the surgical techniques for lens extraction in primary angle closure glaucoma. So these are the biometric parameters in PACG, I think in a series of 75 eyes. They had a mean age of about 58 years. The spherical equivalent was 0.76 diopters. The intraocular pressure was 26.7 millimeters of mercury. The axial length was 22.64. The AQD, that's the space between the endothelium and the anterior surface of the capsule, was 2.05. The lens volt was 0.93, and the lens thickness was about 4.83 millimeters. So this is what you're starting with. This is the eye that you have in front of you. So what are we dealing with? We're dealing with an eye where the angles are completely zip closed, where the AQD is less, and we have a very large lens, or at least the diameter of the lens is very, very much, and there is a significant lens volt actually. So the lens volt in this particular patient is 1.16. That's really significant. So how do you treat these patients preoperatively? Topical steroids are considered a very important mode of therapy in eyes presenting with PACG. Topical and systemic pressure lowering agents are very important. Some patients may respond and others may not respond to efforts to lower IOP, or maybe not respond significantly to efforts. So this depends on the edema, the degree of ischemia of the iris. Some RDs do not respond to the use of pilocarpine and others do. The clinical presentation differs significantly. One may get a patient of PACG with symptoms of angle closure, especially redness, pain, hazy cornea, and elevated intraocular pressure, or one may get a primary angle closure glaucoma patient with a rather quiescent presentation with mild or moderately elevated IOP, with even clear corneas and no significant clinical symptoms. PACG patients with significantly elevated IOP often do not respond to medications. There is then the possibility of waiting patiently while the IOP may continue to remain significantly elevated. Or there is a possibility of doing surgery even at this stage with elevated IOP, while clinically our senses would like the IOP to be controlled and the eye to be quiet. However, given such a situation, elevated IOP is not a contraindication to surgery in PACG and may be the only way forward. For us, when we have an AQD of 2.25 millimeters, we want to be very cautious, and most patients of PACG have an AQD of less than 2.25 millimeters. Doing capsulorhexis is a challenge, so when you put in the capsulorhexis forceps and you puncture just the center and the chamber doesn't collapse, then that is already an indication that things are going to be all right as you do capsulorhexis. When the chamber shallows, then the arms of the capsulorhexis forceps tend to press on the capsule and you may get a linear tear, and that is something that you should be very cautious about. That's not at all an indication that you'll be able to complete capsulorhexis safely in such a patient actually. So therefore, it is very important that we need to deepen the anterior chamber in such a patient before proceeding any further. And once, of course, you do capsulorhexis, then the fluidics of the current phacoemulsification machines are excellent, that they will allow you to do safe phacoemulsification. So normally we would give a peribulbar block. We do a side port and we put in adrenaline, we put an air bubble, we put the blue dye, the viscoelastic, and if the air bubble sits without being pushed out, you're in luck. It really is an indication that things are going to be all right. If the air bubble gets pushed out partially or moderately, or if the air bubble sits only in the pupillary area, that means it's a small air bubble. These are indications that there is a mechanism which is not allowing deepening, or which is not going to allow deepening of the anterior chamber. Non-deepening of the anterior chamber indicates that it will be difficult to complete the capsulorhexis, and therefore AC deepening is needed. The cause of an AC not deepening enough is not known, but we may consider the possibility of a congested choroid and the role of choroidal pulsations. Todd zonules may be another cause actually. So there are two ways of deepening the anterior chamber. One is by doing a limited vitrectomy. So if you have the help of a colleague, or by doing a vitreous stab. A vitreous stab for malignant glaucoma was popularized many decades ago by Morton Grant and Paul Chandler. With the advent of vitrectomy, it was not considered safe or fashionable. We consider it not fashionable, but we do consider it quite safe even in PACG eyes actually. We use a 2 ml syringe with a 20 gauge needle. We make sure that the piston moves smoothly. 3.5 millimeters behind the limbus, we pass the needle 8 to 10 millimeters into the mid-vitreous after exposing the sclera. We aspirate the smallest amount of vitreous possible, which could just be 0.1 or a little more than that. It's difficult sometimes clinically to control the exact amount of vitreous that you are going to aspirate, so you need to be extremely cautious, and one has to go by a minimalistic tendency and ask your assistant also to watch how much you are aspirating actually. This is followed by a significant anterior chamber deepening. You need to get used to operating with a deep anterior chamber, but if the anterior chamber has deepened a little bit more than what you would have liked, then we would recommend that you may inject some normal saline into the vitreous to build up the pressure and to bring the AC depth to where you would be able to operate. The chance of getting a complication with vitreous tap is extremely low, and we have never had a lens or a vitreous touch over many, many years actually. So this is a patient that I'm showing you a surgery with, where actually the chamber shallowed, and I put in a needle and you can see the vertical streak of capsular rhexis. And so then we had to go for a vitreous tap in this patient to deepen the anterior chamber, following which it was not at all difficult to do the surgery. And this is the suture that is being given to the sclerostomy that you've created using the 20 gauge needle. And then we complete the capsular rhexis, and you can see that that's not so difficult. And that was a time when I was not using the blue dye to stain the anterior capsule, but I do use that now more often. And the remaining surgery is just like any other surgery actually. So this is, I want to show you what happens with the air bubble actually. This is a patient that we followed up for 15 years without touching him. He's a one-eyed patient. We just kept him on drops. He did very well. This stayed all right actually. And then we had to operate because he developed angle closure, not acute, but angle closure glaucoma actually. And you saw how the bubble was very small, and then we did a vitreous tap, and then we were able to reform the bubble, and then we knew that we'd be able to do a vitrectomy. And post-operatively, at 5 months, the intraocular pressure is 16 millimeters of mercury on no medication. And this is another case, and you can see that you had a lens volt of 0.83, intraocular pressure of 32 millimeters on glaucoma medication. He had a cup disc ratio of 0.8. The angles were completely zipped closed, and the disc was completely or almost completely cupped. And you can see the ganglion cell layer, and you can see the thinning of the retinal nerve fiber layer here. And this is a patient that we did combined surgery, and the pupils had the posterior synechia, and you can see what we do for such patients. So, the chamber formed. As soon as the chamber forms, you know that you're out of the woods. You're going to be able to do surgery. And we use the vitrectomy scissors to, release the posterior synechia, and also to enlarge sphincterotomies and enlarge the size of the pupil. And, that gives you enough space and enough ability to do cataract surgery. And so the intraocular pressure at 1 year follow-up was 15 millimeters of mercury on prostaglandins actually. And this is another patient with classical iris atrophy and posterior synechia, and we use the vitreous scissors again to cut through the pupillary sphincter, do the capsular rhexis, and so lens extraction is a sight-saving procedure in eyes with PACG, and despite the skills required, it's eminently possible to do safe lens extraction in PACG eyes. Clinical skills and technology today allow for surgery in eyes with primary angle closure glaucoma. And this is a pyramid that I keep on showing just to tell you how we have evolved and what are the opportunities that are available for us. Thank you all very much.